Manjunath sir, we can start in next few minutes, and Sanjana ma'am will be started.
So, Soumya ma'am, it's 3, 2, 1. Over to you, Soumya ma'am.
Good evening, everyone, and welcome to today's One for All talk, that is Metabolic Symphony and the Invisible Frontier, One for All harmonization of therapies for optimal outcomes. So, traditionally, diabetes management predominantly focused on glycemic control, and success was often defined by how effectively we can lower the HbA1c control. And however, our understanding for type 2 diabetes has evolved significantly. So today we recognize that type 2 diabetes is not simply a disorder of elevated glucose level. It is a very complex metabolic condition which involves multiple interconnected abnormalities as well, which include the insulin resistance as well as beta cell dysfunction with impaired incretin activity. So, managing such a multifaceted disease require more than a single pathway target. So it requires a coordinated as well as a patient-centric approach that harmonizes the therapy to address multiple metabolic defects simultaneously. So today's concept is also what today's program describes as the metabolic symphony. So to explore this evolving paradigm, we are privileged to have with us two distinguished experts, Dr. Manjunath, a cardiologist joining from Sri Jayadeva Hospital, Mysore, and Dr. Sanjana ma'am, endocrinologist, JSS Hospital, Mysore. Thank you, doctors, for joining with us today. So let's begin the discussion. So, with the first segment, that understanding the metabolic symphony. The question to Dr. Sanjana ma'am from an endo perspective. So, how do you interpret the concept of metabolic symphony in your day-to-day diabetes care or practice?
Thank you, ma'am, for that question. I would say metabolic symphony would be the other way of reframing what we have always been seen as Defronzo's omnis octet at the present treacherous 13 or 15. It says that the type 2 DM is not a single disease or a single gene related disease, it's a multifaceted disorder. A metabolic symphony, this says that there are early individual pathways which would lead to beta cell dysfunction, increased insulin sensitivity, or incretin failure, which would in combined lead to all the dysfunctions. And also there are many invisible frontiers which would flag these symptoms, which would say that early onset dysglycemia, all those. The diabetes, what we see might be a tip of an iceberg with many invisible frontiers, what I would say at the underlying dysglycemia, even before starting of the actual diabetes.
Okay. So, Dr. Manjunath, sir, over to you. How, according from a cardio perspective, how do you interpret the concept of metabolic symphony?
Basically, it's always nowadays, whichever diseases we see in our day-to-day lives, not only related to cardio or endocrine, it comes with a package. Very few patient I see only cardiac. It comes with diabetes, dyslipidemia, even thyroid also, with some brain issues, CVA. So everything is like mixed diseases which we see. In spite we finished our MBBS, MD, and cardiology, we see everything as a package. And when we come to the diabetes, it is like, the diabetic capital is India now. It's going to become India because of the population increases and because of the other risk factors, mainly no exercise, junk food, and so many things. So, whenever as a cardiologist, I explain regarding the cause for the heart attack or any heart diseases, dyslipidemia or cholesterol, which we tell, it's mainly because of the background of risk factor is maximum patients out of 10 patients in roughly, if we discuss, 50% has diabetes. Other 50% will be around 3 people will be pre-diabetic. Only 2 patients are non-diabetic, which we see in an elderly above 50 to 60 years of age, what we have seen. And nowadays, in spite of diseases getting worsening, you have more and more drugs, like you have come with the linagliptin and combination of DABA, whatever this IGLT inhibitor like dapagliflozin, DPS. DPP4 inhibitor, linagliptin. But why, as a cardiologist, linagliptin, where I use is in two things, where a patient is not getting controlled and other oral hypoglycemic drugs like sitagliptin or whichever thing. And this will help, which I have seen. And patient, elderly patient, and some with the kidney issues patients. It's much safer for me to use with the dapagliflozin with combination of linaclotide. This patient come with the sugar not controlled and less issues of hypoglycemia, which you have seen like clinical patients as well as day-to-day OPD patients. So that is one much edge which I like to tell in this time.
Yes, sir. Perfect, sir. So, Dr. Sanjana, ma'am, over to you. Is the diabetes care nowadays becoming more addressed with the multiple metabolic abnormalities simultaneously, or rather focus on mainly the HbA1c alone? So, what has changed your treatment philosophy over the clinical practice?
Initially, I would say it was just a stepwise way, treatment go slowly, give some time. But now the whatever we have seen is a bit different. The very moment we come across the first patient, what we see is to target all the most of the pathways which is causing. As Sir said, we can't define that this is caused by only this particular category, but we know what are the pathophysiology, what is leading to these things. So it is what we think is to hit hard at the starting rather than going slow one by one. So I would prefer going through drugs which would mostly take care of most of the pathways like increasing sensitivity or increasing muscular uptake or increasing on the other side it might be linagliptin like thing which would have increased in insulin release or in case of incretin effects. So I would say it is better to start with a drug which would have a way covering most of the targets than going step by step.
Okay, ma'am. Yes, ma'am. So over to you, sir. Sir, from a cardiologist perspective, does harmonized therapy helps with a broader cardiometabolic continuum, or do you think that diabetes and cardiovascular disease can still be treated as a separate entities?
Can you repeat the
Yes, sir.
question
Yes,
once
sir.
again, please?
From a cardiology perspective, how do you feel that harmonized therapies it helps to addresses the cardiometabolic continuum? So rather than a diabetes alone, so do you think that diabetes and cardiovascular disease can be separately treated, or it should be treated jointly?
Uh, in the question only the answer. We have to treat it. We can't treat it separately, madam. It has to be go like a brother and sister, or a brother and combination treatment is always better. So that initially, I remember some 3 years before when dapagliflozin was initially introduced. That time we used to start this tablet. In that time, some people used to have a phobia that dapagliflozin is for the diabetic only, not for the heart previously. But now, after 2, 3 years, everyone has the idea that dapagliflozin is used for the heart failure also. In spite, that is one of the this. So we should be going as a team, not only treating separate diabetes or heart thing. We have to combine both the diabetic, which can be improved, which can help in the heart failure patient, and similarly, which are better for the heart conditions improvement, other than the other previously which we used to use glimepiride, etc., other uh, sulfonylureas, which we are using right now. But when we need to control the HbA1c much better, because HbA1c is like the indicator which help us to see he should not end up with macro and micro complication of diabetes. In spite, today only just now I have seen one diabetic with heart patient. His sugar, RBS and his PPBS are good, but HbA1c is high. Today's FBS and PPBS is good, but it doesn't mean HbA1c is high. Still, he might go for macro complications also. So I changed it
Yes,
from his previous medicines to the newer drugs which we are using right now. So this is
yes,
like going with combination with the diabetes heart is better.
yes, sir. Thank you, sir. So, coming back to Dr. Sanjana ma'am, whether the concept of this harmonization, how do you select the combination therapies, ma'am? So, whether it is a traditional stepwise escalation approach or you directly upfront start the combination therapy?
It mainly depends upon the patient's glycemic control, ma'am. If the patient's glycemic control is bad or something like that, I would upfront definitely go for a combination therapy. And most of the case, it has always been a combination therapy with a metformin and the DPP-4 inhibitors. And I would prefer a combination therapy. Like as I said, it will have a, as we know, diabetes is a multifaceted disease. It is better to hit hard at the beginning and rather than start running when the complications occur. So I would say that at the beginning, combination therapy, which covers most of the pathophysiological process of diabetes, just like presence of any increased insulin sensitivity, decreased insulin sensitivity, I mean. And other thing is that defective insulin release, or in other way, beta cell failure or beta cell fatigue. All those things, it's better to address at the upfront in the beginning rather than taking long time and waiting till the complications to happen.
Okay. So, sir, Manjunath sir, do you agree that looking the side of patient of diabetes as well as a cardiovascular risk? So, do you think combining the both therapies over simply escalating a monotherapy could be better, or what's your stepwise approach?
The patient which I see is having complication, macro and micro complication of the diabetes. So ultimately, combination will be better for the my set of patient which I see, and they're already on a lot of drugs. I'll tell you frankly, you and me of anyone taking a tablet is very difficult. So I try to give a combination and minimize the drug load for them. So I go with a combination. If he comes with the good control, then definitely I de-escalate to the minimum what medicines I can do.
Okay, sir. So, coming back to Sanjana ma'am, in your clinical experience, what make diabetes combination easier to be adherent for the patients to stay on? Any particular factors that are there?
To be frank, the one of the most important thing what they would look for is a simpler regimen, like once a day regimen, rather than going to 2 times, 3 times as a 4 times a regimen. Along with that, better tolerability with less of side effects, not much of nausea, vomiting. And the second thing is that less of risk factors like, yeah, it should not cause like recurrent hypoglycemia, and also it should be acceptable from the patient side point. Like it should not just cause the patient comes with diabetes and give him obesity. That is not how. It should not cause any weight gain or weight loss. It should be weight neutral. That will also affect the patient's complaints. And also it should be pocket friendly to the patients, I feel. That also makes in a long diabetes is not something where you'll start a medication and the patient will stop after a time. It is most of the time it is going to be there for the patient's life. So even that has to be addressed. So everything, a simpler regimen, better tolerability, better safety profile, and a better economical cost will all matter, ma'am, for the patient to get adhered to the treatment for a long duration.
Okay. So coming back to Dr. Manjunath sir, do you believe that treatment complexity like clinical inertia or something has become a hidden barrier for a long-term cardiovascular outcomes?
No, it's only about the counseling and the patient to your confidence. The patient is always one not to take tablet. If so, we should convince them and we should tell him frankly why we are giving this tablet and what is the need for this tablet. If that part is clear to the patient, he will take it. And in advance, before giving any tablets, if you feel any hypoglycemia symptoms might come, educate him. The education about the medicine, about the disease to the patient is very important. That will give you more confidence to take the tablet than simply prescribing and allowing him to take like this. Mainly complication, education regarding the tablet and the disease. These 3 points is very important for him to understand the use of the tablets.
Okay.
That will very help, and that actually helps. One time when you see the patient, you have to tell him the what is the course. Some patient comes to me with a diabetic and cardiac patients also. When hypertensive also we see. They come, can we stop the tablet? This is the simple discussion. Even for madam also they will coming. When can we stop the tablet? And that is one of the biggest my nightmare I can tell you to convince them we'll stop one day. And I have simple guidelines right now. I'll tell you if the sugar comes down, I'll stop it. If the BP gets control, I'll do. Antiplatelet, I tell them directly. It's very difficult to them, but I'll reduce the dosage to whatever I can do after 1 year of PTCA or 2 years. The one thing which I told, we should give them hope, like we'll try to decrease and hope by God grace, the BP and sugar controls down. Definitely will, every physician, every doctor will reduce it. But main, educate them. In spite of this also, some people are drug defaulter, they come, that is their choice. We can't much help in that kind of patients.
Yes, for sure. Education is so important. So coming back to Dr. Sanjana ma'am, so as per your clinical experience, ma'am, do you think that linagliptin can be qualified as a truly one for all gliptin? so that it can be used across the type 2 diabetes continuum patient profile?
I would say yes. Being a patient or being a doctor, what one should expect from our medication is being safe, as I told, with less covering multiple targets. In that way, linagliptin does stand out, ma'am. Like it doesn't cause recurrent hypoglycemia. It is also important the patient once started to continue that he should have less side effects, so that even he starts believing that the drug is working. And also many trials and with combination, without combination, as a single drug or with an insulin, linagliptin has shown truly a beneficial effects with considerable reduction in HbA1c around zero point 0.6 to 0.9% and low hypoglycemia. And one more thing, which is that one of the main thing a diabetic eventually turn out is to have a chronic kidney disease. Most of what the drugs we have is like they require renal dose adjustment are because of hepatic dysfunction. But linagliptin, as we know, that it doesn't require any renal dose adjustment. So, owing to the fact that it has a better safety profile and almost a similar efficacy, a simpler regimen, I would say yes, it is almost closer to being one for all drug in diabetes.
Yes. So coming back to Dr. Manjunath, so sir, from a cardiology standpoint, what role does Lina and its combination does it qualify to be called as a one for all therapy for type 2 diabetes and cardiovascular disease management?
Mainly as a cardiologist, we want sugar to get controlled so that you should not come up with one more block.
Okay.
And second thing, linagliptin comes with minimum dose of 5 milligram, which we know.
Yes, sir.
I had two patients recently. They see the milligram, not the efficiency or the tablet action mechanism action. They're telling that, sir, 5 milligram linagliptin was better than that tablet because psychologically they have that 5 milligram is better than
Yes, sir.
but,
The size of the
like
tablet.
other tablet doses like vidagliptin, which we give 50, 100. So this 5 milligrams
Sitagliptin
because
also 100, yes. That
they
large
discuss
size.
they discuss when they are sitting with their friends and all. Hey, I am taking 100 milligram. This 5 milligram is getting good. So that is one of the very good of linagliptin because DAFA in this combination comes and I some people are better in some uncontrolled who are already on glimepiride high dose or gliclazide, which markedly they take. And in CKD patient, I actually start with linagliptin. It's very good because I'm not in stress that he'll go end up with hypoglycemia. And they have come with, as Madam has told, it comes with good HbA1c control, uh, which I have seen within 1 to 3 months. At least if your sugar is uncontrolled for 9.5, it comes to 7.5. It not drastically come to 6.5 normal, but at least it comes 7 to 7, 8 between, which I have seen. That gives you happiness and the peripheral neuropathy complications are because of diabetes also they are much more reduced than previously. I might be in my some set of patients which I have seen because of the linapride which I have introduced, the diabetic complication like the neuropathy mainly has reduced. It might be my own some detail, some patient, but should ask Madam how she has with this kind of any similar patients have come with them regarding peripheral neuropathy complaint reduced with linagliptin because she'll be much more using this than me, I feel.
Ma'am, in your
Uh,
opinion?
I would say that yes, it might be a part of beneficial effect, but I would say rather than the molecule, it is the diabetic control which is affecting a better outcome. I would say definitely linagliptin has a role to play. I wouldn't deny that, but might be a better glycemic control because of linagliptin, which acts as a confounder. There would have played a actual role. I would say, sir.
Okay. So, Manjunath sir, over to you. That's from a cardiology standpoint that safety, whether safety should take a priority over efficacy. So, in the complex cardiovascular diseases,
Safety versus
efficacy, sir.
see, these both are equally important, madam. You can't leave one, we can't take efficacy, one can't leave safety. Both are important. So the same thing which I'm telling you, again, the same point I like to highlight. If you educate them, the safety also is there and the efficacy also comes.
Okay. Sanjana ma'am, over to you. In the patient profiles of the linagliptin and its combinations, do you think whether it can be used in a sarcopenia patient?
Sarcopenia, I think with the age population, one of the important thing we are seeing today is loss of muscle mass. With the more of education and this thing, people have started noticing. Linagliptin being weight neutral and all those stuff, and with a good combination like with a metformin or something or an insulin, I am sure that linagliptin will be helpful in this sarcopenia patient, knowing that many other drugs which is known to induce sarcopenia, this doesn't have any side effects like such of sarcopenia or anything. This being weight neutral, we don't see any fat loss or a muscle loss with using this DPP-4. So I would say this is beneficial in especially elder population where sarcopenia prevalent is very much, and also plus it has an added safety of being less chances of hypoglycemia. So I would say yes, it is very good in that aspect.
Okay, ma'am. So coming back to Dr. Manjunath, sir, in patients with established coronary artery disease and with a very advanced age group, so how do you prioritize your treatment choices? Like you start with the triple or double combinations of linagliptin?
Basically, I see with the HbA1c and the previous medicines. First step we see in a patient who has coronary disease. If it is controlled HbA1c with the previous medicine who is taking, I refer them back to the regular doctor. Continue. If it is not controlled, then I try to change it to the latest things like a drug. Start with the dapagliflozin, next linagliptin,
Yes.
and background of the age, kidney, other things. And
Okay.
one more slide in which you had given, it was very nice actually. It tells
Yes,
you
sir.
that I just like to highlight that slide.
Yes, sir. Sure.
Simple regime, low dose frequency, better tolerable, cost effective, and patient centered approach. This 5 points are very good actually, which we
Okay.
follow. So it should be combination of these things. If the same medicine can be given in cheaper price, we can give. If it needs, we have to convince them and tell that you have to take.
Okay, sir. So, ma'am, in your opinion, how do you escalate the combination therapy in a complex cardiovascular renal metabolic patients like CKM syndrome patient?
Okay. One thing which we would see is most of the patient, even if they have, whether they have a fasting hyperglycemia or a postprandial hyperglycemia, sometimes an HbA1c gives almost a rough value, whether it is less than 8 or more than 8. We can see whether it is a fasting or whether it is postprandial. Most of the time, fasting it mainly because of hepatic gluconeogenesis or increased insulin resistance. In such cases, we would prefer something which increases the insulin sensitivity. At the same time, we should also look at once the fasting is high, obviously it is a carryover effect that we'll be having that postprandial will also go high. So postprandial should also be taken care of. Postprandial can be taken care of many other drugs and also incretin or DPP-4 inhibitors and also sulfonylureas. But when you're selecting, as Sir said, you should have a complete holistic package. We have to educate the patient regarding that the drug is safe, that it won't cause hypoglycemia, it is tolerable, but also the drug should behave in the same way. So we would take something which is good for that and which suits all that, whatever I have told previously, like it is safe, tolerable, efficacious, low hypoglycemia, weight neutral, which would take off when the postprandial rises. On the other hand, if there is only postprandial hikes, I would suggest something which increases the beta cell function or which acts as a complement to the beta cell functions. It might be insulin or like incretin. That way we will be seeing, and eventually, as we know that diabetes is a progressive disease, we can't just stay or halt the disease, we can just make it less progressive or less causing complications. So eventually I would like to try to see the patient's biochemical control, clinical control, how is he doing, is there any hyperosmotic symptoms, all those things I would like to eventually monitor and then escalate. Eventually, it will be like fasting or postprandial. Based on that, I would start. And if it is not controlling, I would start escalating based on biochemical and clinical parameters.
Okay. Sir, over to you. How do you evaluate whether a therapy complements the patient's metabolic defects?
Sorry.
Sir, am I audible?
Yeah.
Yes, sir. Sir, so how do you evaluate whether a therapy complements the patient's metabolic deficits?
Basically, therapeutic is basically mainly the symptoms, clinical symptoms which we see. Then weight, which we go with the diabetes, etc. And the other blood tests for which we use, like the HbA1c, lipid profile. This all comes in a like a package for us, individualizing the each and every patient, and the tolerating level of the drugs which we give, whether the milligram, TID, OD dose, whatever we tell. Basically, it comes with a package, and it is different to different patient mainly, but I clinically go with the symptomatic things. Next is lab.
So, coming to the end of the discussion, so Dr. Sanjana, ma'am, over to you. What is the key takeaway message for today's session from endo perspective? Yes, ma'am.
From perspective, I would say it is better when you're at starting to start with a combination therapy. Of course, that will be guided by a HbA1c, glycemic control, and various other factors. But at the starting, hit hard. Don't wait till the complications. And combination therapy is better. And it is like to choose a drug which is initially to be say have a good safety profile, less side effects, efficacious, tolerable, and also pocket friendly, so that the patient sticks to the therapy for long. As sir said, at the core, it is the educating the patient. It is not like someone doesn't want to be healthy. Everyone wants to be healthy, but the thing is that everyone has that initial anxiety. Should I start? Should I take it lifelong? Yes, it might be lifelong, but it depends on you also how you manage your lifestyle and control. And having such good drugs like linagliptin in your armamentarium, I think that should not patient can safely take it, and that will also have a positive effect on the patient. So having a molecule which almost covers most of the pathways of diabetes and helps in better efficacy, I would say better control at the starting, hit hard, and don't wait till the complications. A combination therapy at the start would be a better option.
Yes, ma'am. Perfect, ma'am. Thank you, ma'am. So, Dr. Manjunath, sir, over to you. Your key takeaway message and closing remarks.
As we are in the generation where new things comes, and daily new evolvement or new drugs come into market. So as a doctor in cardiology, which I try to is try the latest one and keep to it, which has less complication and pocket friendly. Mainly these two things, if every doctors like madam has told, definitely patient will be first happy, and more than patient will be happy when they come with their diabetic control and clinical profile of the patient. If the patient wants to be happy is by taking less medicines. So the more we try to reduce to the minimum level where he can have a good glycemic control, and lifestyle medication, lifestyle adjustment. What madam had told, I forgot actually. Madam told very important, like weight management and daily exercise. Very important for the. In spite we give the medicine, we should promote them or we should educate them for the exercise thing, which is lacking everything. And food diet also is equally important for the people.
Yes, sir. Perfect, sir. So, thank you both of the doctors. It was a wonderful discussion. So, today's discussion has provided us the valuable insights for evolving landscape of diabetes as well as cardiometabolic care. So, if there is one message that stands out, that is the diabetes management is no longer chasing the glucose numbers alone, but modern care involves the interconnected nature of both the metabolic as well as cardiovascular and renal health. So a true one for all approach is not about finding one therapy for every patient, but rather it is a combination for the right patient and at the right time for creating a personalized therapy, a metabolic symphony that supports a durable and meaningful outcome. So on behalf of entire looping team, I could like to express my sincere gratitude to Dr. Manjunath sir as well as Dr. Sanjana ma'am for joining us today, taking a valuable time, and your expertise has enriched today's discussion and reinforced the importance of multidisciplinary collaboration in diabetes care. So thank you so much for joining us with us today. So thank you participants for joining with us today also. Thank you so much Magica team. So with this I conclude my discussion and session. So thank you so much sir and ma'am.
Thank you.
Thank you.
Thank you so much. So with that,
Good
we
night,
are
sir.
closing this link. Thank you everyone for joining today's